Hello, everyone, and welcome to Frontiers in Substance Use Care, Emerging Topics and Evidence, an immersive podcast series sponsored by the Provider's Clinical Support System, Medications for Opioid Use Disorder. I'm Keena Thakrar, an addiction medicine and infectious disease physician and longtime member of the EMERSA community. For those new to the podcast, EMERSA is a national organization dedicated to bringing together disciplines and perspectives to strengthen substance use care through collaboration, evidence-based practice, education, and advocacy. This series explores the evolving landscape of substance use and addiction care. In each episode, we highlight emerging research, new clinical challenges, and innovative care models shaping the future of the field. If today's conversation sparks ideas for your own practice, we invite you to explore additional education opportunities and resources available through EMERSA at emersa.org. And now let's turn to today's episode. Despite effective medications for opioid use disorder, most people who could benefit still lack access to treatment. Pharmacists, often the most accessible healthcare professionals, are uniquely positioned to help close this gap, particularly in rural and underserved communities. What does pharmacist-led addiction care look like in practice? And how can expanding pharmacist roles improve treatment access, retention, and patient outcomes? In today's episode, we explore how pharmacy-based models are helping expand access to life-saving medications, strengthen interdisciplinary care teams, and reshape how substance use treatment is delivered. We'll also examine the policy changes, clinical innovations, and real-world strategies making this work possible. Joining us today is our host, Dr. Jeffrey Bratberg, a pharmacist, researcher, and national leader in advancing pharmacist roles in opioid safety and opioid use disorder treatment. His work focuses on expanding medication access and developing policy and practice innovations to improve care. He is joined by Dr. Corrine Joan Franklin, a pharmacist and healthcare leader whose work builds pharmacist-physician peer partnerships to expand access to evidence-based treatment and reduce overdose risk, and Dr. Kate Morton, Chief Clinical Officer at Albuquerque Healthcare for the Homeless and a clinical pharmacist specializing in HIV care and opioid use disorder treatment. The presenters report nothing to disclose. Thank you for being here. Let's get started.
All right. Thank you, Keena. And welcome, everyone. Thanks for joining us. I'm your host, Dr. Jeffrey Bratberg, and on today's episode focuses on one of my favorite topics, pharmacist-delivered addiction care. We are joined today by CJ Franklin and Kate Morton, two incredible guests with experience in direct patient care, research, and education related to opioid use disorder. We're so glad you're here, CJ.
Hello.
And welcome, Kate.
Hello. Thank you so much for having me.
Absolutely. So I'm going to start to frame our conversation by sharing some of our learning objectives for the listeners. These are the key themes we hope you'll carry with you after listening. So we'll start by talking about how pharmacist involvement in addiction care impacts treatment outcomes. We'll talk about how federal and state policy changes have enabled expanded pharmacist roles in medications for opioid use disorder delivery and management. We'll look at some barriers, right? Some system level barriers and facilitators to how to scale these pharmacist-led MOUD services and recognize opportunities for pharmacists to lead addiction care services, whether it's training or clinical practice or even implementation science. So let's jump in. So let's start with you, Kate. Describe for our listeners your practice setting and how you participate in MOUD care.
Sure. So I'm based in New Mexico, and I work for an organization that's a federally qualified health center, FQHC, called Albuquerque Healthcare for the Homeless. And I serve as the chief clinical officer. So not only do I get the distinct pleasure to lead all of our medical, dental, and pharmacy teams, but I also am a practicing pharmacist clinician, which is a separate pharmacy license that pharmacists can hold here in New Mexico that allows me to be able to prescribe medications. And so I am in clinic once a week, and I get to see patients where I help them get started on or continue their medication for opioid use disorder.
So just to be clear, you are acting in the same way as anyone who can get a DEA registration. So you have a DEA registration so you can prescribe controlled substances like buprenorphine there?
Absolutely, yes. So I have actually a bunch of different licenses. I have my dispensing pharmacist license. I have my pharmacist clinician license, which again is a separate licensed here in New Mexico. I have a controlled substance license from the state Board of Pharmacy, and then I have a DEA license, which is federal. And I need all of those things together to enable me to prescribe buprenorphine and treat patients.
Okay, a lot of steps there. We'll definitely hear more about all those things in a little bit. I want to hear from CJ Franklin. Why don't you talk about your practice site and how you've impacted and provided addiction care?
Thank you, Jeff. I'm a little all over the place, if you would say. I have worked with physicians collaboratively on their collaborative practice agreements in an academic healthcare setting, as well as working with physicians' well-being in the community, in community pharmacy practice. I have worked with other pharmacists in kind of like a project manager role to oversee the collaborative working pairing of addiction providers and community pharmacists and kind of guiding as a primary investigator for one of my projects. I'm based in the District of Columbia and licensed in the District of Columbia, Maryland, and Virginia. One of the things I do is help in providing opioid overdose education and naloxone distribution, and also in providing and sharing, doing some teachings with healthcare professionals in all those states. So a little all over the place sounds about right.
That's great. So it's great that you're doing research and education. I don't want to. I think this might be a good opportunity for to transition to Kate talking about you are implementing a grant to educate pharmacists in New Mexico. Do you want to talk a little bit about that right now?
Sure. Yeah. So, one of the main things that we're seeing in New Mexico is that we have this additional licensure designation, this pharmacist clinician license. And now that the X waiver went away in 2023, so pharmacists or anybody with the DEA license could prescribe buprenorphine. I sort of expected a lot more pharmacist clinicians to really be jumping at this opportunity to expand care for our patients. And we haven't really seen that play out. There's really only about a handful of us in the state that are prescribing now. And so I was able to get some funding from an organization called Vital Strategies. And I've developed an 8-hour certification course for pharmacist clinicians in New Mexico that's really meant to be very practical. So we go through all of the clinical guidelines and sort of the how-tos around helping to walk a patient through getting started on buprenorphine and continuing on their road to recovery, as well as some of the practical pieces. So, how do you get a DEA license, and how do you structure this in your clinical site? How do you create a template in your EMR, for example, that can really help to support making sure that you tuck in all the details of the clinical visit, and then folks come and spend some time with me in clinic too, where they can shadow and really just get a feel for the cadence of the visit and sort of how to do this work so that we can take the guesswork out of it. I think a lot of folks are, feel like they don't have the education or the experience to do this work. And so I think really bringing folks in and having them see that it's not rocket science. It's really about being super compassionate and, of course, knowing what you're doing, understanding the science, understanding some of the details of addiction medicine, but really being able to meet people where they are and guide them through this process. So doing a lot of education around this work as well.
I think it's important to know you both would agree that that sounds like how we should do all teaching for all professions for all chronic diseases, right? If you can, that's a that's a great model for how to do diabetes care, whether you're a nurse or a physician or a PA or an NP, see patients, be compassionate, see all the factors that are involved. And then again, we have all these logistical components just to lead up to being an independent practitioner. And I'm guessing that 8-hour training is also, we should tell our audience that that's what's required to get a DEA registration. I assume that's meeting the MATE Act.
Yes, correct.
Yeah. Okay, well let's switch gears. So that's being an independent practice and research and education and promoting policies that already exist, that independent practice there. And we'll talk more about that in a little bit. CJ, you talked about collaborative practice agreements in an academic medical setting where you cared for patients with opioid use disorder. Do you want to talk a little bit more about that and kind of set the stage for what CPAs are and what it allowed you to do in that setting?
Absolutely. So under the CPA, we were able to, the CPA I worked under, you can have different degrees of collaborative practice agreements. When I say CPAs, it's collaborative practice agreements. So collaborative practice agreements, for anyone who's not aware, are agreements, and some states have, if not most states now, allow pharmacists and prescribers to enter into these agreements, which are called collaborative practice agreements, that allow them to manage persons with different disease states. Not It's not isolated to opioid use disorder, collaboratively and following evidence-based guidelines. The collaborative practice are agreements in the academic healthcare setting where I worked with other providers. I think what was very loose and practical. I was able to initiate, make changes, right, and discontinue persons with opioid use disorders treatment under the supervision and in collaboration with the prescribers in that setting. And in addition to those, I was able to do what pharmacists do, right? Work with other providers outside of that academic setting to help manage their other disease states, which I think they added a lot of value to the persons who came into our outpatient clinic, because there were a lot of medication related interventions that I could say I had time for, that the prescriber psychiatrist in that practice setting necessarily did not have time for. And it also led to more referrals to other providers after looking at certain indicators for disease management, right? A specific example, for because the collaborative practice agreement was opioid use disorder and psychiatric disorders. A lot of our psychiatric medications have side effects which require management of certain metabolic disorders, that kind of thing.
Yeah, I think it's important to sort of think of the pharmacist being a hub and a spoke, just as maybe physicians who are addiction physicians work with NPs or they work with other primary care providers who manage chronic diseases. And so, pharmacists are there to do comprehensive medication management, and comprehensive medication management applies to the chronic disease of opioid use disorder or other, substance use disorders from start to finish, monitoring, ordering tests. I assume that you guys did, in your practices, you were allowed to do soup to nuts, to do all those things. Is that right? Kate, you want to talk about like how you ordered tests? You talked about this education and being very practical. I think our listeners are probably like, but are you ordering tests and evaluating them? How does that work?
Yeah, absolutely. So the way that it works in New Mexico under this pharmacist clinician license is we have an independent license. So I'm signing my own prescriptions, my own lab orders. I'm doing everything under that license. But I do have a guideline or protocol in which I work under that is signed off on by my supervising physician. And then after the fact, my supervising physician reviews 10% of my charts and will give me feedback or, give me recommendations for how to improve my practice moving forward. So there are some similarities in that way. Mine is also written very broadly, much like CJ's. So I'm in the context of a primary care setting here at Healthcare for the Homeless. And so we're a federally qualified health center, and I work on a collaborative team with physicians, nurse practitioners, psych nurse practitioners. We have behavioral health, social services, all sorts of folks that are really wrapping around and helping to treat the patients that we serve, both in clinic and on outreach. And so the way that that works is patients will come see me for buprenorphine. I will order new patient labs. I will ensure that the patient meets the criteria for an opioid use disorder. We'll talk through different treatment modalities and different options for patients. We use the sublingual versions of Suboxone, naloxone combo. We also are able to order and prescribe and administer the long-acting buprenorphine injections. And so that's also really popular among our patients. And really, we try to just meet them where they are and provide as much support as we possibly can. And we do all of this in the context of a primary care clinic. So I'm not acting as an addiction medicine specialist per se. I'm really looking at the whole patient and understanding what else the patient may need, whether that's a referral to more specialized care, whether that's a referral to one of my colleagues who work on the primary care team with me, or whether that's strictly for their opioid use disorder. We really try and think more holistically about the patient.
It's really meeting the goals. I actually was honored to be a consultant with the AHRQ on a project to update their toolkit to integrate OUD treatment into primary care. And it's interesting. My advice to them is like, you should mention pharmacists because I know Kate Morton is doing this work right now. And it's interesting. It really is sort of discipline agnostic. It's saying if you do primary care, you're seeing people who have OUD and they need all the services you just described. And I have to shout out to your multidisciplinary efforts there. It sounds like a mini immersa all in one clinic, and that's really wonderful to hear.
Yeah,
Um,
I think one other thing I'll add is just that part of that includes screening for infectious diseases. We do a lot of screening for HIV, hepatitis, STIs, syphilis, and then we'll provide treatment, of course, if any of those come back positive. We're really trying to take a more holistic and primary care look at the patient. And all of those things really are part of primary care. I think we used to think about some of those things as more specialized clinical services. But at this point, we really feel here at Healthcare for the Homeless that it's all part of primary care, and patients should be offered treatment or prevention too. That includes HIV prevention.
Yeah, I think there's such an overlap, and especially with your expertise and training between behavioral health and substance use disorder, and we'll jump to CJ to say about we've been trying to incorporate behavioral health into primary care. We've been trying to incorporate HIV testing and treatment into primary care, and really all these things come together. And a lot of these treatments are medications, so it seems natural that a pharmacist should be we have pharmacists who are HIV specialists and are able to prescribe pre-exposure and post-exposure prophylaxis. And my call is they should be treating people with addiction too, if you're going to be selecting them. So all the sort of public health services that pharmacists or our listeners are probably aware of pharmacists doing, they're seeing people with SUD, and we need to empower them to do that. So CJ, what was your practice in comparison or contrast to what Kate could do independently with her license under your CPA? As you said, you had a broad range of things. You did referrals. Is there like where was testing in that, or was there anything else that you'd like to point out?
It was similar, however, I feel where Kate mentions there was perhaps 10%, there is 10% oversight of her patients and the patients she sees. It would be 100%. In
Right.
it would be more there would be more oversight for that pharmacist. There was testing involved, not necessarily only to OUD, but for other tests that are required for other mental health disorders for patients seen. And the tests were all done. Unlike Kate, who would do it with her license, all of my testing orders and seeing patients were under the physician's NPI, knowing that there was the collaborative practice agreement in place. So
Right.
so that was the major difference is, even though it was done in that setting, it was done, as the physician when you look at the system. So there would be 2 sign-offs for each,
Right.
patient encounter. It would be the sign-off with the pharmacist who did the encounter, and the physician would have to sign off.
And that's very, very common in ambulatory care practice with pharmacists where they're essentially doing all of the work. Maybe we'll talk about billing a little bit. They're doing incident to billing. They're not credentialed with insurers, like, again, in some states, nurse practitioners and physician associates and things like that. We'll get into the policy things. I think this is a good time to sort of solidify the care that you guys have provided or are providing. Do you have a memorable, patient experience where the fact that you were in the CPA or that you had the expertise to manage opioid use disorder for those primary care patients. Anyone can jump in with something memorable that they thought about.
I think one of the things that comes to mind is so one of the ways that folks can get care here at Healthcare for the Homeless, we really try and make it as low barrier as possible for folks to come in, get on the buprenorphine, and stay on it. And so one of the mechanisms for that care delivery are our integrated behavioral health and primary care group visits. So we have two sessions a week where folks can just come in as a walk-in, they can drop in, they come to a 45-minute behavioral health group session. So they go through some sort of therapeutic training or teaching. There's oftentimes breathing techniques or other coping techniques that the behavioral health clinician will go through with them. And then towards the end of the visit, the patients see the prescribing provider one-on-one to get a refill of the buprenorphine. And early on in this practice model, there was a patient who came in, and I happened to be the prescriber in that group that day. And he came in and he said, "I'm here because I really want to transition from methadone over to buprenorphine." And so for all the clinicians listening, this is sometimes a very challenging process because methadone is so long acting, and this patient was experiencing homelessness. And so there were a lot of things sort of working against him in terms of barriers around this. And so I was able to work very closely with the patient. He was coming in on a daily basis for the first probably week of his care while we were working in collaboration with his methadone clinic, as well as prescribing him buprenorphine to make that transition, along with comfort medications to really help with some of those withdrawal symptoms and some of the other pieces of that very difficult transition. And I think it was so helpful to have a pharmacist at the table because really understanding the mechanisms of both of the ways that those medications act in the body, and also having a little bit more time to be able to see this patient on a very, very regular basis so that we could really support him through this difficult transition. I think that was something that stands out to me, and definitely a success story. That patient is still in care a year later, coming to see us regularly for their buprenorphine. And it was a big success story in my mind, and something that stands out to me.
Yeah, that's fantastic. I think the thing that I hear the most there before we go to CJ is the fact that they came in every day. And something that CJ and I have been working on is how do we get buprenorphine in community pharmacies, which are the most convenient healthcare, access point for folks, where, theoretically somebody could come into a community pharmacy every day to get their addiction care. So CJ, were there any patient anecdotes that you have to share in terms of your role?
Yes, I'm sure, like Kate, there are plenty, but I'll try to pick, a two. One of them, and these were always great learning opportunities for students we work with and residents we work with. One is the opportunity to educate patients about stigma.
Mm,
A common occurrence that would happen is when doing maybe medication reconciliations with some of the persons we saw with opioid use disorder, they would not mention that they were on buprenorphine. However, I could see that they were on, the buprenorphine naloxone combination. And that always opened up the conversation of, getting them more comfortable. I would let them disclose all their medications, and I would see more than one patient would not mention they were on buprenorphine, and they actually had been on for a while. But it would give the opportunity to build trust, especially not just with the pharmacists, all healthcare professionals. I would kind of use that opportunity to bridge the gap. And, well, what about buprenorphine? How are you taking that? And we could talk about stigma. It opened up conversations, perhaps with stigma that they had experienced at even community pharmacies, because
mhm.
perhaps they were not disclosing it to me because they thought I was a pharmacist who would not want to dispense their buprenorphine. That's another there's another anecdote there. So those opportunities when doing med recs with patients within the clinic always opened opportunities to have conversations that would help reduce stigma in a sense and make them more comfortable. And I would always try to bring the discussion and the importance of disclosing buprenorphine use with other providers and letting them know that, they need to understand there are potential interactions. So maybe not in this clinic, in another clinic, it would be important to disclose that. And then there's the stigma and perhaps the issue with access of buprenorphine in our community pharmacy settings. A lot of times I had the opportunity to work with community pharmacists where in those local community pharmacies, we had our patients who were not able to get their buprenorphine prescription filled. However, this should not be the case. It would always be a welcome when you had the pharmacist from the clinic call the community pharmacist and say, hey, I'm a pharmacist on the team and we are working with this person, really trying to get their fill so that they don't go through the weekend without their prescription. Is there a way we can get them an emergency fill while we work on this script coming your way? So that was a role I always played, and it was always welcome from the community pharmacies. Now, every practice doesn't have a pharmacist embedded, although we all talk about, every practice should be able to have a pharmacist embedded if they can. But being in that position, it always helped some of our patients who had access issues with buprenorphine. So those are some anecdotes that I could really stick out.
Yeah, really powerful stuff. And I think knowing the audience, that's probably the first thing that jumps to mind when they see pharmacist and addiction as they think about access to medications and this and the barriers to that. And it really comes from a policy barrier. So I appreciate you sharing those anecdotes. Very, very powerful in your practice site. Very illuminating. So Kate, you alluded to this in your intro about policy changes in the federal landscape and things that have changed in your state that's helped facilitated this work. Is there anything else that you want to just summarize sort of what has changed in your state or what has changed federally that allows pharmacists to be trained and to initiate and prescribe buprenorphine there?
Yeah, absolutely. So we've had this edition of the pharmacist-clinician licensure since 1992. I think we were the first state that had a designation like this. So the fact that pharmacist clinicians could prescribe medications and really treat chronic and acute illness has been around for decades. The piece that was missing was really the removal of the X waiver, because even as early as the 90s, pharmacist clinicians could also have a DEA license, but they were really limited to only prescribing medications that were not for substance use disorder because of the X waiver. So the Data Act that was passed in 2000 allowed for buprenorphine to be dispensed by pharmacies and to be available in more of a primary care setting and not in a methadone clinic type setting. But that was initially limited only to physicians. Then years and years later, it was expanded finally to nurse practitioners and PAs. But pharmacists in any capacity were unable to really engage in that level of treatment. And so it wasn't until 2023 when the X waiver went away as part of the MAT Act, which really now allows anybody who can carry a DEA license to prescribe buprenorphine. And so that was the final step that needed to happen in order for pharmacist clinicians with a DEA license in New Mexico to prescribe. And pharmacists can do this in many other states as well at this point. I'm most familiar with New Mexico, of course, but this is something that's really becoming more commonplace around the country. So I think that was federally one of the big steps forward. The other piece that I will say that New Mexico has in place that has been very, very helpful is we have a parity act for billing and our payment system with Medicaid. So that allows for pharmacists, clinicians, nurse practitioners, PAs, physicians, all of us who are independently credentialed for payment by any of our payers and under Medicaid in particular, to be able to be reimbursed at the same rate across the board. So that means that if I see a patient in clinic and my physician colleague sees a patient in clinic, we're billing and being reimbursed at the same rate as one another. And that really helps because a lot of times pharmacists care feels like it's uncompensated or compensated differently than other primary care or specialty providers. And so this was really something that leveled the playing field and made it possible for employers to employ a pharmacist and be able to afford to do that and really lean on that business model. So I think that was the other thing at the state level that really helped us push forward for pharmacist clinician prescribing.
So we all want to be like New Mexico and the
Yes, we do.
states that allow you to independently practice, get a DEA, be credentialed with an insurer and get paid at equitable rates. CJ and I talk all the time about how, and CJ's in 3 states. I want to hear about contrast and compare the policies around billing and CPA and DEA in the states that you're licensed in there, or in DC and Maryland and Virginia.
Absolutely. We all
It's a
we
short
all wanna
answer.
be we all we all wanna be, like pharmacists in New Mexico, right? We all wanna be like Kate. But
Yeah.
here and we are in states and really it's most of the states are similar to what we're experiencing in DC, Maryland, and Virginia. Some of the policy changes we have seen, do allow, pharmacists recognize pharmacists as providers for Medicaid, right? Um, Maryland is one of those states that allows for reimbursement of some pharmacy services. Maryland and Virginia, I'm aware of. You can get reimbursement for some pharmacy services. However, we're still not on a similar level, right? It's not equal reimbursement as what when you compare other provider specialties, physicians, NPs, nurse practitioners, and the likes. And in DC, we are still working to get that implemented so pharmacists can get reimbursement from Medicaid for some services. However, there are still a lot of barriers to getting paid for services provided, which is
Mhm.
also a reason why, even though the MATE Act encouraged, when it comes to substance use disorders, the MATE Act encouraged training for more pharmacists to be involved and adequately capable of caring for persons with opioid use disorder. A lot of pharmacists who are adequately trained, ready and willing to increase access for these patients struggle with, justifying their existence, getting reimbursement for their
Mhm.
services. In the academic setting, I know one of the things we were working on is tracking the services and interventions that pharmacists, as a pharmacist, I was able to provide so we could kind of quantify it and see how we could figure out incident to billing. So those are some of the struggles when it is not, the regulation is not up to par with everywhere. So,
One of the things, I have to put a plug in for my website, that the Foundation for Opioid Response Efforts were pleasantly funded for me. It's called pharmacybridge.org, and it actually talks about all the questions per state, including DC and Puerto Rico, in terms of, can the pharmacist prescribe buprenorphine in a CPA, like in DC, or independently, like New Mexico? What is the billing status, like you said, in Virginia and Maryland? Can it be Medicaid, or can it be all payers, like in New Mexico, including commercial third-party payers? Can you get credentialed there? The other question is, can you inject long-acting injectable buprenorphine, which Kate also said can be done in New Mexico? Can you do that in a CPA, or can you do it independently? Can you do telehealth? And so we have these great maps and great descriptions about what's the law, where is the law. It's only updated through October 2024, but it's a really great thing, I think, for listeners to go to pharmacybridge.org. We keep expanding it to talk about buprenorphine policies in each state. So, for example, some states limit how high a regimen you can prescribe in their state, and other sort of idiosyncrasies that way. Like in Rhode Island, buprenorphine is decriminalized. And so all of that, we have links to resources. And I think it's really a first step for folks to say, gee, I'm a pharmacist. What can I do in my state? Or for people who aren't pharmacists, who are prescribing clinicians, to say, I'd really like to have a pharmacist. Boy, if I have a pharmacist and they get paid the same, I can justify it, like Kate said. Or you're a policymaker going, boy, how do I address rural health? I need to pay pharmacists to do the services. Otherwise, they're not going to provide them. And actually, probably need to pay pharmacists for these services where they're needed so that the pharmacy stays open to do other things. And that's where I know all of us have sort of agreed upon to say you're saving the pharmacy by allowing them to do addiction care and all the other primary care that goes with it and medication management. And you're saving people's lives by increasing the workforce with an existing workforce, right? The pharmacists are there, and what we can do. CJ, you talked about our next question. You sort of led into the next question about barriers you've encountered and how pharmacists take a more active role. You said that in the CPA, the prescribing clinician has to review all of your orders and be co-signed. Is there anything else that you've seen as barriers to getting CPAs for addiction care?
Well, some of the barriers is because the CPA is based on a willing provider. One of the biggest
Right.
barriers is the provider's knowledge of what pharmacists can do, and not all addiction providers are aware of how qualified pharmacists are, necessarily, and the abilities or what interventions we could provide. That's one of the biggest barriers is everyone is not up to speed on what pharmacists can do. We work on continuing to educate individuals on what pharmacists can do under collaborative practice agreements. So that's one of the biggest barriers is not having willing providers to even sign these CPAs.
Right. So even if you could bill for services, if you can only bill within a CPA, you still have that barrier of a provider who needs to be either in your clinic or a provider who is willing to work with community pharmacists in that way. Kate, what kinds of barriers have you faced? Like you've talked about, you're allowed to do all this stuff and bill, and you got a grant to educate more pharmacists. The X waiver went away. Why do you think that is, or how do you plan to overcome some of those barriers?
Yeah, I think some of the things that I see from the prescriber side are folks not feeling comfortable, sort of getting started with this work or, CJ mentioned earlier the stigma. I think that still, even though we're healthcare providers, I,
Mhm.
I still see even colleagues with sort of this held stigma and these held biases around treatment for opioid use disorder. I think and also I think just maybe not understanding how buprenorphine works and how life-saving it is and how it, can be a treatment for withdrawal and all these other pieces. I think on the dispensing side, when you really look at some of the pharmacies and pharmacists in the community, I think there's a lot of fear and maybe folks feeling a little timid about dispensing buprenorphine. I think part of that is that in pharmacy school, we're really trained to be the gatekeepers. For those on the call who are not aware, all pharmacists have to take our regular boards as well as a pharmacy law exam separately in order to be licensed in a particular state. And so I think right out of school, we're really taught to scrutinize every single prescription that comes through, making sure that it's safe, making sure that it's legal, it's not, forged or there's no diversion happening, all of these things. And so I think that putting pharmacists in that position as sort of being the gatekeepers really makes it difficult to dispensing medications, including buprenorphine. And so I think lots of education and anything that we can do to decrease that stigma and to help folks understand that it really is no different than dispensing insulin or metformin for somebody who has diabetes, right? And I really try and relay that in folks that I'm training. I think those are some of the big pieces that are facing pharmacists doing this work. However, I will say that I have had really great success with when providing training and really talking through some of these concerns and issues with pharmacists. it's I've seen a very big turnaround in sort of some of those stigmatized pieces and pharmacist thoughts and comfort level in terms of addiction management. So I do think that we're moving in the right direction, and I think there's a lot of hope there too. I think it's something that pharmacists need to sort of be given the space to think about things rather than really just narrowly focused on the legal and regulatory components.
And I'd like to add since we're still in the context of barriers to CPA, thank you for that. I'm going to shift a little to the community pharmacy setting, even though I've talked about my practice more in the ambulatory care setting. Some of the barriers we've seen, and Jeff and I talk about this a lot. I am the principal investigator for a project funded by the Foundation for Opioid Response Efforts as well. And that project is really looking at the collaborative management of persons with opioid use disorder between pharmacists, physicians, and peer recovery specialists within the community pharmacy. This project has opened up, we now know a lot of barriers to implementing a collaborative practice agreement between physicians and pharmacists in the community pharmacy setting specifically. Some of those barriers are physicians perhaps resistance to sending referrals of stable patients to the community pharmacist to continue managing to increase access. And also, it's not necessarily resistance because maybe they don't trust, because we've witnessed providers who have signed collaborative practice agreements, but then there are barriers within figuring out payment, just figuring out workflows. Payers scrutinize a lot of physicians who prescribe medications for opioid use disorder. And just trying to navigate those barriers with payer audits has caused barriers. Having pharmacists who are not recognized as individual providers has created barriers. The CPAs are there to, kind of counteract those barriers, but we've seen barriers in implementing CPAs with those community pharmacists as well. One of the biggest barriers we've encountered in addition to stigma.
Yeah, thanks so much for sharing that. I think that we agree that we want to increase access in any way, but if there's too many hurdles, if there's too many barriers, people aren't going to do it. And especially if people don't get paid, despite having to go through the same credentialing process. That those are kind of those solutions. So you both mentioned some solutions. I want to try to close this out here. I think we've talked about the barriers, and I like that Kate talked about hope. So let's talk about some hope here. Kate, what do you think the future of pharmacist involvement in MOUD care looks like?
I mean, I envision a world where it's easier and less expensive to access buprenorphine than it is street drugs. I mean, I think that's if we really want to move the needle and really help people access care that's life-saving and life-changing, that's what we have to be able to do. And I think that community pharmacies, in particular in rural settings that don't have a lot of other access to specialized or primary care services, I think the community pharmacy is a perfect avenue for that. And we saw this a lot in COVID. I mean, pharmacies were and
Mhm.
pharmacists were really empowered to be able to test and treat, to be able to vaccinate. I mean, all of these pieces really leaning on the community pharmacy as a modality to administer public health efforts. And I think that's really what we're talking about here. And we've talked about some of these barriers. I think they're not insurmountable. Some states are farther along than others, and I think great callback to the website that you put together, Jeff, pharmacybridge.org, because I think that's a great starting point for folks who want to work on moving the needle to sort of see what's going on in my state and how can we even start to have these conversations. But yeah, I'd like to see addiction management be readily available for all types of different substance use disorders at the community pharmacy level. And I think that's the direction we need to go to really get things done and help the most people.
Great answer. CJ, what do you think the future of pharmacist involvement in MOUD care looks like for you?
Well, I think the future of pharmacists, my vision is, there need to be policy changes that take away more of these hurdles. Um, Knowing where the resources are. Jeff, your website, pharmacybridges.org, is that what it is a great
Pharmacy
resource.
Bridge. There's only one bridge.
Pharmacy Bridge. There we go. The bridge. Yes. Pharmacybridge.org is a great resource. Know what you can do in your state when it comes to practicing as a pharmacist in managing patients with opioid use disorder. Another good resource, which I also use, even though I plan on using Jeff's website more, is the National Alliance, NASPA, National Alliance for State Pharmacy Associations, has great resources on collaborative practice agreements. Right now, involvement in a lot of states as a pharmacist in management of persons with opioid use disorder involves enrolling, getting into a collaborative practice agreement. So learn these resources, get in touch with your addiction providers, let them know what you can do, provide some educational services, some in service, educate them, let them know what you can do as a pharmacist and getting to these CPAs. Now, these CPAs exist. We've talked about barriers and hurdles in implementing these CPAs, and I think our legislature needs to catch up so that an individual can be able to walk into a community pharmacy. We have talked about how accessible community pharmacists are for everyone and managing any disease states. So I think an individual should be able to walk into a community pharmacy with a community pharmacist who has been adequately trained in addiction management and be able to not only pick up their buprenorphine prescription, but also have it prescribed by that pharmacist.
Remove those gaps. Well, thank you so much for joining us today. What great summaries. I'm feeling hopeful. CJ and Kate, we appreciate your time and your expertise and all the service you provide to your communities. I want to highlight a few key takeaways from today's conversation. It seems like there are ways to implement this, and you need to either promote the policies that already exist or to advocate for changes because we have the template, right? We have the template in the states that allow DEA. We have everyone should get involved with the Rural Health Transformation Project, which is helping elevate and expand pharmacy's scope of practice. So we need to advocate for those system level changes for any pharmacist and any personnel to reduce pharmacy and addiction deserts simultaneously, keep pharmacies in business. Those policies can be found at pharmacybridge.org. There's lots of toolkits for implementation. So it's one thing, as Kate described, to have the policies in place. It's another thing that you need to provide education. I'm devoted as a professor to incorporate more addiction care into all of our health professional curriculum, ideally interprofessionally, so that we can get those teams together, like CJ talked about, and do those CPAs. And so, those listening, you're already designated a champion for implementation and a champion for advocates. Work with federally qualified health centers, work with your state associations, whether addiction or pharmacy or medicine or nursing, work with the national organizations. Again, it's interdisciplinary care, like at Kate's clinic and at the clinics that CJ worked at, and it's going to be an interdisciplinary effort that advocates for this change. For the listeners, thank you so much for spending time and being engaged with us. If you found this episode helpful, please share it with a colleague or someone else in your network.
Thank you so much, Jeff.
Thanks, Jeff. Thanks for having me.
That was Dr. Corinne Joan Franklin and Dr. Kate Morton in conversation with Dr. Jeffrey Bratberg on Frontiers in Substance Use Care, Emerging Topics and Evidence. Thank you to Dr. Bratberg, Dr. Franklin, and Kate for sharing your experience and leadership, and thank you for listening. We hope you'll tune in next month for the next episode of Frontiers in Substance Use Care, when we explore how hospitals are responding to in-hospital substance use and developing more effective patient-centered approaches to care. In the meantime, join us in 2 weeks for the next episode of Immerse's other podcast series, Substance Use Across the Lifespan, Supporting Every Stage, where we explore how substance use care changes across the lifespan, from childhood through older adulthood. This Immerse podcast series is created in partnership with the Providers Clinical Support System, Medications for Opioid Use Disorder. To learn more about PCSS, MOUD, and Immerse, please visit pcssnow.org and immerse.org. Technical production is provided by Podpaste. Funding for this initiative was made possible in part by grant number 1H79T1086770 from SAMHSA. The views expressed in this podcast do not necessarily reflect the official policies of the Department of Health and Human Services, nor does mention of trade names or organizations imply endorsement by the U.S. government. Disclaimer. The information, opinions, and recommendations presented in this podcast are for general informational purposes only and should not be considered medical advice. This podcast is not intending to replace professional medical consultation, diagnosis, or treatment. Any reliance on the information provided in this podcast is at your own discretion. While every effort is made to present accurate and up-to-date information, Immersa makes no warranty, guarantee, or representation regarding the accuracy or sufficiency of the content featured. The views expressed by guests are their own and do not necessarily reflect the views of Immersa. Their appearance on this podcast does not imply an endorsement by Immersa of them, their viewpoints, or any entity they represent. Unless explicitly stated otherwise, Immersa does not endorse, approve, recommend, or certify any information, product, process, service, or organization mentioned in this podcast. Information from this podcast should not be referenced in any way that implies such approval or endorsement. Immersa expressly disclaims all liability for any direct, indirect, incidental, or other damages resulting from an individual's use of, reference to, reliance on, or inability to use this podcast or the information presented in it.